So,
All right, here we are. We are live this morning with Dr. Kortesis, plastic surgeon, and Danielle Valoras. She is our physician's assistant, and we're here to talk Explant this morning. So good morning, guys. Thank you both for being here.
Good morning, Tara. Dr. K.
good morning. How's everybody doing?
Hanging in there, still quarantined.
Yes, we are quarantined, but thankfully we're healthy, which is the main thing, right?
Amen. Yes, for sure.
And Tara, where are you? Are you in Ohio?
I'm in Jersey.
And you're in Jersey. I thought you were Ohio.
Yeah,
I didn't realize you were like at the hub of it all.
yeah, one of the hot spots, Jersey, New York. Yeah, yep.
Thank God for virtual reality.
Yeah, for sure. Definitely. Dr. K, you're in North Carolina also?
Yep, Charlotte.
Okay. Awesome.
We haven't been hit too hard here in Charlotte per se, but it is growing. The numbers are growing daily, and not nearly as bad as Jersey or New York, that's for sure.
Right. Yeah, it's rough. Oops, sorry. Never mind.
Well, while we're waiting for folks, I have some great questions for you, Dr. K.
Yeah, sure.
Not quite personal, but I know I was like maybe at least one of the first of your BII experiences, right? I mean, I know you have been explanting. Well, first, tell us how long. When did you start practice, and how long have you been doing plastic surgery? And
Man, it feels like forever, honestly, at this point. I have to tell my kids a little bit about like how long it takes to become a plastic surgeon, and they get overwhelmed. They're like, "Really? You have to do high school and then college, then med school, and then residency." So it's been a while now. I started residency in 2003, finished in 2009. So I've been doing plastic surgery since 2003, which is kind of crazy to think about at this point. I've been in private practice for 11 years in Charlotte.
wow! And where did you do your residency?
At Wake Forest.
My alma mater.
Demon Deep by heart. I mean, I grew up there. So honestly, like for me, Winston-Salem has a special place.
Oh, I had no idea.
So yeah, I did med school and residency at Wake, and then moved to Charlotte. Like any good man, I moved to Charlotte because of my wife. She wanted to live here. So I do whatever she wants. It makes it a lot easier that way.
We're already loving you. We're already loving you.
I know how it is. I know what you need to do.
What do they say? Happy wife, happy life. Yeah. So, I have cats, so it's all good.
And now I have a little girl, so I know how that it's going to be even worse. It's going to like spoil my little Greek goddess princess.
That's what happens. Yeah. So what was your, even for me, I think we explanted October 2015. And I'm wondering what your experience with now that you know and have, like, how many have you explanted actually? Quite a few. I think he froze.
Oh, so Danielle, your explant was in 2015?
Yeah. Yep.
Okay.
Wait. My implants were December 2015. My explant was October 2017. Sorry about that.
Okay, no, that's okay. I was wondering also. I also got my implants in 15, explanted in 18.
So. Oh, really? What did you have?
What kind?
Yeah.
I had Sientra textured, silicone.
Oh. I had Allergan Natural, I believe.
Okay. Were yours the recalled ones or?
Well, they were already out, so I didn't really follow that too close. I should look it up. I think not.
Okay.
But what I'm finding in the clients that I see is that the later productions, like the 2015, 14, those people seem to get sick faster, or they become more aware faster that they have symptoms that may or may not be due to the implants, right?
Right. Yes.
How quick did you get because were yours like a gel?
Yeah, they were the cohesive gel, and I noticed symptoms right away. I mean, I didn't realize it was from them right away, but I noticed them right away. Yeah.
Yeah, I mean, go ahead.
No, go ahead.
Yeah, the journey, like I really thought it was the physicalness of the implant versus the physiological cellular dysfunction of autoimmune and all that kind of good stuff.
Mm-hmm.
And so it took about a year for me to be like, all right, let's get these out.
Right. So you didn't have yours very long either. I find it so crazy that.
And there was so much wrestling in my head. I don't know, maybe it was denial, but like, who do you believe? What do you do? Like that drove me crazy. And then the longer I waited, the sicker I got. So it's an elective procedure and everyone thinks you're a little loopy for removing something you just put in and spent all this money for. And now you're going to spend more to take them out. So I just kept trying physical therapy and, like all this kind of natural ways to get better, and then taking the antibiotics. I think we're getting texts here.
Yeah. And it wasn't working. Well, we just have my mom says, good morning. Hi, Mom.
Hey, Mom.
She's always tuning in. But yeah, and I think that it's important to know, it's always good to try, physical therapy and all of those different interventions. However, without the explant, I just feel like your body cannot fully heal. So I think Dr. K coming back to us. Hello.
Yay.
Hi. He's really having trouble with whatever's going on there.
And so that's Dr. Kortesis. Meaning in the black screen there.
That's what he looks like frozen. I have him frozen on my screen. So we don't know how many did he say how many explants he's done so far?
No, I'm curious to know. I think the first year or like that, I want to say between him and his partners, probably about 500, but I could be wrong.
Okay. That's right. He's part of a team, right? Team of 3 surgeons, is it?
Yeah. Hunstead, Kortesis, Bahardi.
Okay.
Oh, here he is.
I'm back.
Remove. There we
go. I'm sorry about the trouble.
That's okay. It happens.
Yeah, so let's just jump right in. How many explants do you think you've done to date?
I'm sorry, you froze on me again, real quick. Do you mind?
How many explants do you think you guys have done per date?
We were looking at our numbers recently, and we're trying to collect our data so we can present some of the.
Oh man,
he's freezing.
No, there he is.
Hello again.
You're keeping us in suspense.
Technical difficulties. I don't know where I left you, but I said we are in the midst of collecting all our data so we can present all this information to the world. And it's close to about 500 cases, which is pretty amazing to see. And what we've noticed, preliminary data so far, is that over 90% of patients feel better. And satisfaction's near kind of 100%. And most patients.
Would love to know what satisfaction means.
Back.
Oh man, this is a juicy conversation.
I know. We might have to.
Okay.
Are you there?
Can you see me and hear me now?
Yes.
Oh my goodness. I've done 1 million of these over the past 3 weeks, and this has never happened. So I don't know what's going on today.
Oh, I'm so sorry.
No, I apologize. So I don't know where I dropped off, but the good news is what we've seen is that patients get better. And, if you do the right stuff, they ultimately get better, which is amazing.
That's awesome. What kind of symptoms do they come to you with generally? What do you see most?
I mean, honestly, it is anything under the sun, from back pain, breast pain, rashes, tingling, and brain fog, not feeling well, generalized fatigue. And I mean, it's honestly a myriad of different symptoms, but I would say the most common would be breast pain and just generalized fatigue and mental fuzziness or fog is what, some people refer to.
Yeah.
Those are the most common that I hear.
Are you and your partner still implanting at this point?
Yeah, good question. So, I think the growing theory right now behind a lot of this is obviously there are certain patients that, again, these are all theories because nothing's actually been proven yet, but there's some patients who just do not do well with foreign objects in their body, or they have a generalized predisposition for whatever reason, plus, potentially some autoimmune phenomenon that can occur. You take that with a foreign device and potentially that causes all the problems. The issue is you currently cannot have, there's no diagnostic test to be able to see who has those criteria to have problems with implantation. So back to your original question, do we still do it? Yeah, as a practice we do, but I would tell you our numbers are drastically smaller than where they were. And I think a lot of this has to do with awareness, and it's groups like yours or everywhere across the country, and it's awareness and getting individuals informed consent about what this foreign device can do long term. That way, patients know what's to happen long term.
Right.
That's super important because I think once patients know some of these concerns, I think that's one of the reasons why numbers are so drastically smaller these days.
Right.
Yeah, and just even cosmetically, it seems like the trend is for smaller, at least in the chest area, right?
More natural, smaller. People want more of an athletic look. That's why fat grafting has been such a tremendous value to our practice. And I would say of the augmentations that we do, 90% are fat grafting.
Okay. And when you're doing the augmentations, like how does your informed consent look now as compared to when you first started practicing?
Well, I mean, because of the advances that we've seen in the research that's going on, that we have more information about BII, we have more information about ALCL, and those are 100% super important to discuss with every patient.
Okay.
I mean, I think and patients need to know that implants are not a lifetime device. If you decide to go down that road of getting an implant, it is not a lifetime device, and you're pretty much buying yourself another surgery.
Yeah.
Either a removal, replacement, or whatever it is.
Yeah. Well, thank you for keeping everybody informed. We appreciate that. That's for sure.
Of course. I mean, you have to. Honestly, we're in the day of transparency. The more transparent you are, the more upfront you are with patients, they're going to learn it anyway. And so patients need to be their own advocate. They need to learn about their body. They need to know what's going on and present that to the physician. Gone are the days of this paternalistic type of medicine where the doctor sits down and says, this is what you're doing. This is how you're doing it. It doesn't work that way anymore. I mean, literally, you have to be an advocate for your body. You know your body better than any other physician out there, and you just got to fight for it. And I'm a big believer in that.
Thank you.
Yeah, he sat through a nice PowerPoint presentation I made for him. Like, no, I have something wrong, and here's how or why, or I don't know.
But Danielle, it's important, right? I mean, you have to fight for yourself and what you feel and what you know.
Yeah. And, what's interesting in the whole conversation is, especially almost 2.5 years ago, we didn't know, you as a practitioner, me as a practitioner, like looking into it. I mean, I work with Class 3 medical devices for a living, and we just didn't know what we didn't know. And so that was for me, that was a unique time, brain fog wise. And then it's a unique time to try to I mean, where do you stand when you don't know? So let's try to research it and look it out. And you were really great. You were always, what do you want me to do? How can I help you? Like, you have not left my side with those words in every text.
Well, thank you for saying that. Honestly, for me, it's all, I think every doctor and practitioner, whoever's taking care of patient one, has to listen, right? That's number one, right? If you can't listen, then you're not doing your job. You know, you can't look at an x-ray. You can't just do an exam and say, oh, everything's okay, leave the room. You have to listen and understand what's truly going on.
Yeah, and especially for BII, you can't, there's no lab that says you have X. Now, if your symptoms of autoimmune get so far, like you end up with lupus or, you know, the declaration of X, Y, and Z, then you have that, but you still haven't found the root cause in that timeline or that, you know, thing. And while this is about breast implants, it's also about IUDs and dental implants and, you know, many other implants. And it's not just women.
And Danielle, you know that it's not just the surgical removal, right? There's all this other stuff that has to happen post-operatively as well. And, you know, we don't know yet. And this is part of the research that everything needs to happen. It's like, we don't know yet how long having this device or how long you're having symptoms takes you to really recover from things, right? Why is it in some patients they feel better immediately and that they never get worse? And why in some patients it takes them forever? And why in some patients some symptoms go away and others don't? And those are the questions that we as practitioners need to figure out so that we can help patients better.
Agreed. Totally agreed. Tara, did your symptoms go away? Like, I know right at Explant, I felt better. I mean, going from like horrible to anything, it just felt so much better, right? Like, I mean, I remember waking up going, I can breathe, I can do all this. And that lasted for a good 3 to 4 months. And then I got walloped. How did you fend after Explant?
It sounds like you just told my story.
Oh.
Yeah, I woke up from surgery feeling 100% better, and even so much sat in the hotel room with my husband, and he said, "You're there's more life in you now than there was 3 years ago." So it was a huge, drastic change. But then I have had certainly my flares, and you know, mine was probably a good 3 to 4 months in. And then it happened again a couple, you know, months later. And so it's been in waves for sure. And I'm just trying to figure out what works best for me.
Yeah, I will say, just recently I had a pseudobursa removed by Dr. K. And since then, I feel like I've hit a new axis of better health. Like, I mean, not that I am swinging from trees, but feel like I could, but he won't let me yet.
The key is honestly to get everybody back to their pre-implant self as fast as possible, right? You know, it's like get everything back to its anatomic structure from the breast to the muscle, and then getting you back to doing normal activity as fast as possible.
Can we speak to a little bit of what muscle repair is and when it's needed at Explant and what that looks like for folks? Because I know that there's a lot of people on the on that, I don't know if they're listening now, but on some of the sites that they wonder if their doctor did the repair or how do they know they need it?
You know, what we've learned, and again, this has been an evolution, right? The more we do these cases, the more we learn, and the more and that's just with any medicine. You learn from your first case to your next case, and if you're not, then you're not doing your patients justice. And so what we've learned, there's 2 reasons to be able to do muscle repairs. And typically, I would say, you know, 99.9% of the time, we're trying to achieve this to do the muscle repair. And the 2 reasons are 1, cosmetically, and 2, functionally. And I'll speak to the cosmetic part first. We know in order to prevent any sort of adhesions or problems with how the breast tether down to itself, you need to return everything back to its anatomical structure. And the reason for that, if a patient's really thin and there's no bridge between the tissues and their rib cage, you can create an adhesion. But if you can create a glide plane and put the muscle back down to where it was, you now have an anatomic structure back to where it was, and there's a glide plane that allows that tethering effect not to happen. So there's a cosmetic reason to do muscle repair. So yes, we attempt it on every patient. And secondarily is functionally, right? Like you want to be able to put everything back down to its anatomic location so that you can have full function.
Yeah.
Back.
So the glide plane, and I think that's also why when you put in the drain post explant, do you do that all the time? And if you do, is the tubing around inside the guide plane or below it, or I'm wondering.
So the way the kind of the anatomy sits, right? Your muscle attaches to the humerus here, sternum, and then it has loose attachments down to the IMF, where people say it's kind of loosely attached to the ribs there. There is you put it underneath the muscle because that's where the space typically is. And again, this is in cases where the implant's been placed underneath the muscle. But because of how the muscle lays, you will get access to on top of the muscle as well. So it's kind of in both positions, but you typically snake it in on the undersurface, but it drains both spaces.
And so there's a happy dance, right? Where if you leave it in too long, then it dries out and the glide plane could be affected potentially. And then if you don't have it in long enough, you can develop other issues.
Correct. It is a catch-22. And I would say I use drains in all my cases. I know there's some surgeons out there who don't use drains for various reasons. But again, what I've noticed is you can probably cause more problems not leaving a drain in, including seromas, pseudoburses, muscle not sticking down to where it needs to be, which then leads to potentially other problems. Or then you have adhesions because you have to wrap yourself so tight to the undersurface of, you have to wrap your breasts to prevent any sort of fluid formation.
Yeah, and I've been searching for a couple of the women. I never knew the lingo glide plane, which is great. But I'm wondering if that is stuck with adhesions, are there things like laser or, maybe some physical therapy? I wish Tom was on because he's a great manual body worker to help potentially with adhesions. But how difficult do you think that is to gain more movement and flexibility once it's adhered?
It's hard at that point. I think you have this initial period typically to try to get it done correctly. And then once you have that problem, it's really difficult to correct without having to go through future surgical interventions.
Yeah.
Now you can try, obviously not everybody wants to go back to do another round of surgery for fat transfer or muscle repair or whatever it is. So you want to hope to not have to do that. And in those cases, you're doing massage, you're doing laser treatments, you're doing cupping to try to, but again, there's.
No.
You were at a good point and you froze.
I said, I was trying to think what else.
Cupping, and then there's.
Oh yeah. So, and there's cupping, but those in of itself are not benign treatments. You can have potential complications with those treatments, and you have to keep going back repeatedly for those services. And patients don't necessarily want to do that. Again, that's what I realized, that the more you do surgery, we've learned nuances to try to prevent a lot of these issues up front.
Yeah.
Yeah. Danielle, we have a question. This lady's saying that when she gets her mammogram, they always do an ultrasound, and she's been told that everything looks good. She sees the explant photos, and these implants are coming out looking pretty rough. She's had them for 23 years and has a lot of symptoms of BII. Can she still have BII and the implants not be encased and horrible looking? So I know the answer, but I'd love for you guys to speak, like what have you seen coming out of some of these women? Have you seen things looking perfect? And because that's how mine came out. Mine came out looking absolutely perfect, but I was on death's door. So what do you see?
I can give you my 2 cents, and I'd love to hear what Danielle has to say. But there's no direct correlation with how it looks internally to how patients feel at all. And so that leads me to believe that there's more going on the microscopic level than there is on the visual level. And so there are occasions where you see, hard capsules, ruptured implants, and you take them out, they feel better. But there's no direct correlation. And I've seen it with saline, I've seen it with 4th generation and 5th generation silicone gel, both textured and smooth. Again, where the capsule looks benign, or the structures look benign, but patients still feel better after explantation. So again, there's no direct correlation.
Right.
I mean, I can just say ditto. And Tara, from me too. And I think my capsules were, normal, and the breast implants were not ruptured. And I had a lot of connective tissue issues for myself. How I liken it to, because we don't know any better, but this is what I talk to clients about when they still have their breast implants and they're curious. There's no definitive test for breast implant illness. I will say that when you have a foreign object in your body will develop scar tissue to protect you from it. That's what your body's designed to do. That's what a capsule is. And that alone creates an immune system drain. And that in and of itself creates a potential for nutrient deficiencies, because you're constantly going to protect yourself from X, whether it's a virus, a bacteria, a breast implant, an IUD, or what have you. So you're going to be constantly protecting 24/7. And for some of us, that's a big drain. Even if you chase it with filling the buckets, like the B vitamins and magnesium and things like that, right? So I look at it as like you're maintaining, you have to, and let's say you do exercise and you get more irritation, or you get bronchitis, or you stub your toe or break a leg, you now have 2 things to manage and 3 things, and then life gets stressed, and then you turn 40 and 50 and blah, 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 blah. What can your body handle is going to be different than somebody else's. And at some time, there's a payoff and a cost, and we all meet that at some point, regardless. And that's different for everybody. So what I try to do is just make sure I can reduce the toxic load from what I put on my body and to what I put in my body. And if you are sick, you can try that up front. And then for some of my clients, they choose to keep the breast implants in and until they reach a level of life and vitality that they're happy with. Many can't get there because by the time they come to me, they're already exhausted. And then when they remove the implants, they do feel a little better, and there's more cellular work to do. So you can't tell, and it's a diagnosis of exclusion, really. So
Right. Yeah, we have one viewer saying that she was told for 35 years that her single implant was fine. She explanted October 2019, and it had been slowly leaking. So, you can't go by what you see on an imaging.
yeah, and Dr. K, maybe you know more, and I'm not trying to open up a big can of worms, but what I see in people who have that cohesive gel, like their sign to symptoms, like I do a timeline in their intake, right? And it seems like anywhere between 3 and 6 months, the I'll call them the gel people, they get sicker earlier, and I wonder, and they're intact, right? I'm wondering if I think there's like a type of off-gassing, and it's not just the dealing with the, the protective shell and making the shell. Because the people with saline and the people with the older silicone, the people with the older silicone I see come when they've had their replacements. Like I'd say 6 months after they get replaced, because that's like another trauma, another insult as far as surgery, more antibiotics, blah, blah, blah. But I'm really fascinated with how quick these newer ones make people feel. and then it's like an insidious. And they are also, if they've had them in longer, sometimes those are the harder ones to help. And those are the ones who I see their methylation, like they have high arsenic or high mercury and high lead, because it's not, I don't know that it's for sure because the implants have them in them, but I think our bodies can't process that. So I'm wondering if you have any thoughts on that.
Yeah, I mean, right now, based on the little data that we have in our own office, and we're going to try to combine it with other offices to see, again, there's not been a direct correlation yet with any specific type of implant type yet.
Yeah.
And it's been, across the board. And I know I've talked to another physician who does a fair amount of these, and the same thing. They haven't seen a direct correlation yet. Because if we did, then all of a sudden we can say, okay, let's go ahead and stop this particular implant. I don't think it's necessary. But I think more where the research needs to focus, I believe, is on this interface between the implant and the body and what happens at the capsular level. And what is truly going on between that interface. Is it biofilm? Is it something else that your body's doing? And I agree with you, Danielle. I think it's this force of, your body's attacking this object, and it can't heal itself from other stuff. And then as soon as you remove that object and remove the nidus for your body to fight, it can actually heal itself on the other front. And that's why people ultimately feel better. But again, these are all theories. Nothing's been actually proven quite yet. The facts, this is what I tell patients, like the facts are, you have implants with symptoms, you remove implants, you feel better. Now we got to think about everything in between. What's going on in between.
Right. Yeah, for sure.
And to prevent it, right? Because that's the ultimate goal, is if we can prevent this from happening. I mean, your stories are, I hear pretty routinely, and I would venture to say both of you would probably say, and I would love to hear your thoughts, you probably never would have gone the implant route to begin with, knowing what you know now.
No, absolutely not. I would not have. And
I'm sorry,
Danielle, I asked these specific questions to multiple of my doctors. Can I get sick from them? Can they cause cancer? I was assured that everybody does it. They were perfectly safe, and they were lifetime devices.
And you had textured too.
Yes.
So, yeah. No, but Dr. K, I have clients who would and who have and did, like they were informed that if you had an autoimmune condition, this could exacerbate it, or if you had asthma, and they chose to get them. So I don't want to, people do things for different reasons, right? And I just think that if we can now, like you're doing, have informed consent, so it's the empowering of choice, right? Like there are other alternatives. And I did mine for cosmetic, but I can't imagine being a woman with breast cancer and then, what that whole thought process is foreign to me. And then to get breast implants and then get sick from them, let alone maybe even get BII and AI and BIA, ALCL, which is the lymphoma. So there are people. I love that we have choices. I mean, I love that we have innovation. I do. I love it. But informed consent, I think, is a good thing.
I agree with you. As long as people know the possibilities, then they are free to make their own choice, but they need to know.
Yeah.
Tara, it's unfortunate you had that circumstance, but the problem we have, and this is where I've really gone, and I think Danielle feels the same way, is like we're big in education. So the problem is a lot of those surgeons didn't know those facts because the way they were trained, they weren't necessarily lying to you per se, but it was the fact that they were uneducated to all the new data. And so it's up for me and Danielle to promote this and to showcase and give people the data and the information and make them educated so they know.
Yeah. Absolutely. No, absolutely. We have some comments here. Question. When the implant gets sent to pathology, what do they test it for?
The actual implant is, so the question, regarding there's two parts to this, right? It's like what happens to the capsule and what happens to the implant. And you have to test for any sort of microorganism on the implant. And then you have to test for pathology of the capsule. Because again, you want to make sure that there's nothing anatomically going wrong with the capsule. And you need to make sure that there's nothing from a microorganism standpoint on the implant. And so that's basically, in a nutshell, what they're looking for.
Gotcha. Okay. And do you send everything out, for your practice, you send everything out for testing?
Everything gets sent out.
Yeah.
One thing I learned recently, which was awesome, is that the pathology lab saves the capsule for, is it 5 years? So when I showed up with the seroma, they could use the capsule that they already have to test for some things, right?
Is that across the board, or does it go by state, or does everybody save them for that amount of time?
I think it's based on the lab. You have to have a really good relationship with the lab. And if you do, and the pathologist that runs the lab, that it's typically standard to do something like that, but it is very lab dependent.
Okay.
One of the questions I get asked all the time is, which is more specific, the CD30 or the actual definitive pathology exam to look at lymphocytes? And if you ask any pathologist, they'll tell you the path is the more definitive test. If you look under the microscope with and at the cellular level to look at the capsule, it's more specific than a CD30. So that being said, some people can be CD30 positive and not have ALCL, but not vice versa, right? So everybody who has ALCL will be CD30 positive, if that makes sense.
Yeah.
Okay. Yes, I think I get that. We have another question here. Implant and full capsule removed, and it was causing a pulling sensation in one place. After removal in October, it went away, but last month an isolated burning sensation comes intermittently. I know I had a lot of burning pain after my explant for on and off for about a year. Do you see that, you guys?
I'll let Dr. K go first if you, I do.
Yeah, I think it's pretty routine. There's a couple of things that can cause it. One is nerve pain. Your nerves are sort of getting back to normal, and it is this tug and pull of, am I going to be normal? Am I not going to be normal? I always joke around with patients and say that the nerves go on strike. They're like, I'm not going to work. I'm not going to work. I'm not going to work. And then when they come back to work, they're angry, and then they kind of fire here and there, and then it sort of normalizes over time. So it does take time. So it's either nerve pain, or sometimes, again, things are healing. Things are sticking back down, trying to get back to its anatomic location. And you got to think, if you have an adhesion or something that's stuck and and that glide plane kind of moves a little bit, you're going to feel a little burning pain or tugging pain in one particular spot. And if that adhesion kind of rips open, you're going to feel it for a little while.
Yeah.
So yeah, it's very common to see that and hear it.
There are things to look for, maybe it's rare, but for infection and, different kinds of swelling and redness. And so, aside from that, there are things to do from a functional medicine point of view, or integrative way, or an osteopathic way to help with that and to nourish the nerves and to make sure the cells themselves are hydrated, good electrolytes, water, good fats, making sure you digest your fats and things like that too. And then also getting that lymph moving so that muscle, that nerve can heal. But yeah, that's a very common complaint. And I would say even just recently, poor Dr. K, that's some smart pain and some decent itching that can come and go too. And, to ease the fear, especially I think for us BII women, we're so afraid it's going to come back. Like even just saying that sentence, my whole body is like, oh, I don't believe in this too shall pass, because it was, 2+ years of it not passing. But I tell you, this too shall pass. And there are signs to look for, like the redness and the fever and swelling, just to make sure, like, Dr. K, can you give them when they should call? And should they, a year out, it's hard to call the plastic surgeon and be like, hey, but you guys are our first line fighters, because our primary care docs are like, I don't know what to do. It's surgery, but it's a year ago, and they don't know. Like, we don't have anyone to turn to, so you guys are it.
I always tell folks, always call. Don't hesitate. If you have a question, call or text. I want every one of my patients, and they have my cell phone number. I give my cell phone number to everybody, and they can call me, text me 24/7, and I'm a big believer in that. If you have a question, call me.
And text you back on Easter.
I would rather know so that we can talk about it. That's the only way to get through it. Again, it's this connection between patient, surgeon, doctor, and the relationship, and you're doing this together. It's not one person doing it for the other person. It's, we're in this thing together, and we're going to get you to the finish line. And that's ultimately what surgeons try to do.
And one of my goals is to be able to empower or have a place where, like, the BII people can land, because 3 months from now, everyone's going to feel, I think most people feel better after Explant. And even those who feel better in 3 months may need to be able to, like, I need more than just eating right? Who do they go to? And right now, we try to affect the functional medicine community so that each one they go to, they're not restarting the same formula, the same thing. Like, they need a place to land. And so hopefully, like places like your office will be able to manage more. Because I think, even if you think about it, beauty, they say beauty is skin deep and all this kind of stuff. But, like, what if at a plastic surgeon's office, like, you can make the cells healthy and the patient glows from the inside out, and do what they and you want to do on the outside. But I think,
I think it would be a nice marriage of plastic surgery with also some sort of a healing approach. So, like, okay, we're going to take care of your explant here, and we're going to take care of all that, and we'll see you for X amount of months or however long after. But then you're also in our office, welcome to, see so-and-so who's going to help you through that healing process. I think that would be such a nice thing to do.
Well, and that's part of regenerative medicine, right?
Yeah.
Why not do it from the inside out? And
you're speaking my language now. I think there's this marriage between the external and the internal, and you have to do both. Otherwise, you're not gonna be able to help the patient.
Yeah.
Who cares if you look good laying in bed on your deathbed?
Right. Okay, we have, let's see. First of all, that was Mary who had asked that question. And Mary has just written that she feels as though she's almost the poster child for breast implant illness. And Mary, I'm so sorry that you've been through so much, but honestly, just keep at the healing process. You've done the explant, and that is the best thing that you can do for your body. It won't heal without that. But now truly is when the hard work begins in just finding out what is going to help your body and your immune system heal from all of this. So I'm sorry that you've been through such trauma, but there is hope in healing. So just keep at it. All right. So now we have another question. Have you all heard about, oh yeah, so I had Sientra implants, and she's saying, I think Sientra and Silimed are the same company. Is that correct?
So yeah, very interesting. Just a little backstory on that. Silimed is the parent manufacturer of Sientra implants, and so Sientra was a distributor of Silimed.
Okay, and have you had any women with the implants that were in that plant that was in Brazil with the bacteria that, I don't know, there was that whole conspiracy, right, with the...
Yeah, so that company ended up having some issues there because their plant, one, it got recalled because of some air contamination, and then it started in Europe and then moved over to the United States, and then within a week the plant burned down. So that's the Silimed plant where a lot of the Sientra implants did come, but I would say currently the Sientra implant manufacturing facility is in the United States, and it is a separate company in and of itself of Silmed.
Okay.
So initially it was a distributor of Silmed. Now it's independent with its own manufacturing facility in the United States. I think it's in Wisconsin, if I'm not mistaken.
Okay. All right. Thank you. And also, can you touch upon en bloc, total capsulectomy? What do you do and when and why?
Yeah, so this is really good question. And so what most refer to en bloc as is removal of the entire capsule in situ around the implant. And for me and Dr. Bahardi, we do a majority of them in the practice. Our goal is always to do that. Honestly, it's easier for us. We prefer it. It's a more cleaner dissection. Occasionally, the capsule is so stuck to the muscle of the ribs, it can't come out in situ like that. The true definition of en bloc, if patients really want to get into the nitty-gritty details, is a cancer term for removing sarcomas. And when you do an en bloc resection, you typically take healthy tissue around everything. So even though we refer to it as en bloc, and again, the nomenclature is, we always talk about en bloc when I talk to my patients, because that's the nomenclature that they're used to hearing. But that involves removal of the entire capsule. But a true en bloc is a sarcoma cancer operation where you remove a lot of healthy tissue. And in this case, when we're removing the capsule, you don't want to remove any healthy tissue unless you did have a cancer.
It almost seems like in our community, we need to come up with a new term for this process of taking the implant out still encased in the capsule, because I know en bloc is not necessarily the correct term, but we don't have another term, right?
Right. And so again, I always try to tell patients the difference between the two, but we always tend to resort back to using the en bloc terminology because that's what a lot of patients really resonate with, and that's what they understand. But that is complete capsulectomy in situ together with the.
I know this is a little off topic, and I'd love to do one of these for practitioners too. And maybe one of the studies, Dr. K, to think about is I would love to see capsule and healthy tissue, but I'd love to see the inflammatory response in those cells. And I'd love to know more about the inflammatory cells and at what point or at what quantity maybe those need to be removed as well, right? Because in some of the women who explant doesn't necessarily help as drastically as most, I do think there's an inflammatory cascade. I don't know if it's the breast tissue, but there's something in the, maybe even it's the lymph, right? That, it's hard to get past. And just recently experiencing the removal of the seroma, like there's a, I don't know if that was just physical or the inflammation has gone down or what that is, but I think there's something to look at around the whole thing. And when you just said what en bloc really is, I wonder if there isn't some sort of bilayer or something to look at around the capsule.
Yeah, I mean, there definitely is the like we chatted about earlier, the interaction between the tissues and the capsule, right? And that's where a lot of this stuff goes on. And maybe you end up needing further therapy beyond just resection from a surgical perspective. But again, from what we've been taught is always preserve healthy tissue, get rid of all the bad stuff that's around there. Again, trying to achieve everything going back to its anatomic structure as much as possible.
Yeah.
So, back to the original question, complete capsulectomy is just removal of the entire capsule, and then a removal in situ collectively is just a more definitive or precise way of doing a total capsulectomy.
Right. Great. Thank you. And our friend Mary is just mentioning that, so 35 years with implants, and, it seems like maybe things are getting better, but then some things are getting worse. They're sending her for a brain MRI next week. I don't know, Danielle, if you have any, or even Dr. K, but just, I don't know, some women have had these implants for so long.
Yeah.
And to reverse all of that and to heal, I know it takes a long time. It took you that long to get that sick. So I don't know. Do you have anything that you can say?
So I've seen people heal.
Sure.
Right. But I think the biggest thing, and Dr. K, you can speak to this better than I can, is that you've had implants in for 35 years, right? I think that's I don't know what, when you've explanted, say, 10 years, 20 years, 35 years, I think that in and of itself is there's a potential safety conversation, because we know they're not lifetime devices. And so at some point those need to be changed out, taken out, something. And I don't know that delineation. Dr. K, if you can speak to that. And then Mary, there would love to talk more if we have time, or one-on-one or whatever, after Dr. K answers that, because that's a big deal. There's so many women that have them 20 years and 35 years and some 40 years.
Mm-hmm.
I mean, I think that speaks to, the evolution of how we know about medicine and these implants. And, before, I would say when patients were getting them in at that point, they were like, yeah, maybe replace them, but, you'll be good to go. Where now I think we have more information, and we, again, know about ALCL, we know about BII, and who knows whatever else we're going to know about in the next 2 or 3 years, right? This is an evolution of practice. We may get to the point where individuals who want implants are like, I have to have it, or for the breast reconstruction patients who have to have it, that we may say, you know what, you can only have these devices for 5 years and you need to remove them. There's probably going to be
some end
to our thought process behind not keeping them in so long. And I think that there's something going on at the cellular level right there between the interaction of the implant and the breast tissue, and the longer you have it, the worse it is. And so I feel for patients who've had it in for a long time and feeling these symptoms. I do probably think that it's going to take them a little longer to heal. And I feel bad, but there is a light at the end of the tunnel. I promise you. That's what I tell most patients.
Yeah.
Get with the right healthcare practitioners that are going to care, because if they care, they're never going to leave your side, and they're going to be there with you and fight with you the whole time until you get better.
Yeah, it's not a linear journey. It's not like do this, boom, this.
Yeah. So I know we're probably going to start wrapping up, but to end on that note, Dr. K, the ladies who you guys been talking to this morning are just really grateful. Just because you're so open and honest, and not everyone is getting that from their explant surgeon. It seems like these 2 women in particular were not very supported after the explant process. So as a plastic surgeon, what would you tell women to look for when they are interviewing, consulting with surgeons?
Thank you for saying that. And honestly, it's a true honor to be here with you two speaking on this. And I would say BII has sort of changed me in my practice as a whole, in the fact that I've learned to be a better physician and surgeon, just because I tend to be a better listener now. And I think that's number one, like I said, for all surgeons. You have to, or a practitioner for that matter, you have to be a good listener. You have to listen to what patients are going for. But when patients look for a surgeon, one, I think you have to be very comfortable with that person and know that that person is going to take care of you regardless. So you have to feel that comfort level. And then after you get that comfort level, you need to get in the nitty gritty of it and make sure that that surgeon, that person does a lot of these procedures. You don't want to go to somebody who just does, if you're going to have a rhinoplasty and you have your nose done, you don't want to go to the guy down the street that does one a year, unfortunately, right? You want somebody who, this is what they do, and they do a lot of it, because unfortunately it's surgery, it's medicine, things go wrong, things can happen. And you want to have somebody who has so much experience, they're going to limit that, things going wrong, they know what to do, and they know how to take care of patients.
Yeah, absolutely. Thank you so much. And I have a great relationship with my explanting plastic surgeon, and he's come on with me and done this. And he's always going to be my favorite, but you are definitely my second favorite now. You're a blessing to so
Thank you for saying that.
And, thank you so much for helping women the way you do. This isn't just to the women who are suffering, this means everything to them. So thank you from the bottom of my heart on behalf of all of the women that we in our community. Thank you.
Thank you for saying that. And honestly, this is what I tell everybody. I'm happy to help, regardless of somebody having surgery or not having surgery. I know enough now to be able to help people to get them to where they ultimately want to go.
Yeah. And Kara, we can post his contact information, maybe not a cell phone number just yet, but
I wouldn't mind, Danielle. You know, I'm okay with that.
1,000 women today. Hey. For if you think you have breast implant illness, you guys will do a free consult with them. And you're in Charlotte, well, Huntersville, North Carolina, which is right near Charlotte.
Awesome.
And
Yeah.
you do a lot of out of state.
We'll definitely put your contact info in the comments there so that women can find you for sure. Thank you.
Okay, thanks for having me. This is awesome.
I'm
happy to come back anytime, Danielle. Thank you.
Thank you, guys.
Thank you guys so much. I'd like you two to stay with me, but we're going to end the live. So thank you guys for tuning in. We'll see you soon.
Thanks, guys.